Hello everyone, hearty welcome to this year 2024. First of all, let me thank those of you who were with us since this journey of Learn from the Legends began, now nearing 4 years ago in June 2020 with the onset of the pandemic. And now we are into another year with lots of hope and aspirations ahead. Today, we have a true legend who has done extensive work in neonatal respiratory physiology and clinical medicine, Prof. Huayan Zhang. Thank you, madam, for joining today. Today we are going to talk about BPD. BPD is what you're going to discuss, something that is the bread and butter of every neonatologist who takes care of, who looks after intensive care. And to moderate this session, we have two senior neonatologists from India, Dr. Venkatesh, HA from Bangalore, and Dr. Sachin, Shah from Surat. Hearty welcome, Dr. Venkatesh and Dr. Sachin. So, as is the practice, let's straight away get on to the topic. Before that, for initiating the discussions and for the lecture, let me call upon the moderators. Over to you, Dr. Venkatesh and Sachin. You are muted, Venkatesh. Please unmute. Please unmute. Yeah.
Thank you, Dr. Manoj. At the outset, I thank you for inviting me as a moderator for this session. I'm delighted to be as a part of moderatorship for Professor Huayan Zhang. And we all know that the bronchopulmonary dysplasia is a common morbidity in very preterm neonates. And also, it remains very challenging in the management. There is no silver bullet, either in the prevention or in the treatment. More and more we learn, more and more challenges do arise. I think today we have a very eminent speaker, Professor Huayan. I welcome, and we all want to learn quite a lot from you, madam. Thank you very much. I welcome. Over to Sachin.
Yeah, good evening, everyone. And at the outset, I would like to thank Dr. Manoj and the team for inviting us to moderate this session. I won't come into the students and the professor together. If I just want to introduce Dr. Huayan Zhang, then she is a master in respiratory care physiology. If you try to find out what she has done, then if I try listing her achievements, her publication, her research, then I would take about half an hour. So just in brief, to tell her about that, she is the chief and director at the Division of Neonatology and Center for Newborn Care at Guangzhou Women's and Children's Hospital. She's attending neonatologist at the Children's Hospital of Philadelphia and Hospital of University of Pennsylvania. She's the director of the newborn and the infant chronic lung program, infant lung program. She's the associate professor in pediatrics at the University of Pennsylvania. She's the member of the American Academy of Pediatrics and the Society of Pediatric Research in the US. She's the instructor mentor for the NRP in US. She's the master clinician at Children's Hospital, Philadelphia. She's the member of the BPD Collaborative Executive Board in the US. She's a clinical and research focuses on the newborn and infant respiratory support, lung injury prevention, and the prevention of BPD. She has multiple publications, multiple awards and honors. She is the vice chair of the pediatric branch of World Association for Chinese Doctors. She is the vice chair of the perinatal group of maternity hospital branches at Chinese Hospital Association. And still lots and lots of things to go, but I think I will end that she is one of the masters in the topic of chronic lung disease. Multiple publications, multiple research, and associated with most of the active researches. So I feel privileged to invite Dr. Professor Huayan Zhang for delivering a talk on BPD.
Thank you for your invitation and introduction. Let me share my slides now. Okay. All right. Can you see my slides?
Yes, yes.
All right.
Please go ahead.
Okay. Well, thank you very much for inviting me to this great series. I'm so glad that we can all get connected from each other from different parts of the world through this wonderful internet. There have been so many great talks in your series, and I'm feeling very honored to be part of this. So today I was asked to talk about early postnatal care for the prevention of BPD. I thought I would start with reviewing the pathophysiology of BPD and the key preventive strategies based on this pathophysiology of this disease. And then we can focus on discussing more on some of the early postnatal care practices and their roles in the BPD prevention. Before we start, I would like to first report that I have no relevant conflict of interest to report to the audience, and this talk will not discuss any commercial products. At the present time, the pathophysiology of BPD in the very preterm infants, it's thought to be the simultaneous clash of the programs for lung development, lung injury, and lung injury repair over the weeks to months of time that needed to care for these babies in the NICU. However, the pathophysiology of different BPD patients may be different depending on the timing and the combination of exposures. Obviously, to prevent BPD from happening, we need to try to promote lung growth, minimize injuries, and also foster lung repair. We can promote lung growth through providing adequate nutritional support while giving sufficient respiratory support. In the meantime, we need to try very hard to avoid or minimize ventilation-associated injury and also decrease lung inflammation. Let's focus on these aspects in a little more detail. So first, let's talk about nutritional support in the early postnatal days. As we have discussed, the goal is to provide adequate nutrition support to support lung growth and also lung injury repair. There have been multiple studies suggesting inadequate nutritional intake in the early postnatal days may contribute to the development of BPD. In this prospective study of 135 preterm infants born at less than 1,250 grams, infants with BPD had less fluid and caloric intake during the first few weeks of life. They needed longer time to reach full feeds and therefore were on TPN for a longer time. Not surprisingly, these infants gained weight in a slower pace and took much longer time to reach 1,800 grams in weight. In another retrospective cohort study of babies with birth weight less than 1,000 grams and born at less than 28 weeks of gestation. In this study, they looked at ELBW infants, of these ELBW infants, and examined the main daily caloric intake and fluid intake, also macronutrients intake, and growth status in the first 4 weeks of after birth. In 33 babies with no BPD and 33 matched BPD infants born within 30 days apart. They found that the caloric intake, macronutrients intake, and fluid intake during the first 4 weeks of life were lower in infants with BPD. And infants with higher 4-week average daily caloric intake had a decreased risk of BPD. Here are some growth curves. These are 3 growth curves of BPD kids that I have consulted in China in the recent years. I found many infants with severe BPD that came to CHOP due to severe BPD would have similar growth curves. Those babies usually come to CHOP around an average of 40 weeks gestation. However, I often see a growth curve just like this. By the time they came to CHOP, because of their BPD, most of them had significant extrauterine growth restriction. And the poor growth is often more obvious in linear growth. So we call these growths as across the percentiles. And most of these babies are born average for gestational age. And by the time they have established BPD, they have much decrease in weight gain and also significantly decrease in linear growth. However, studies have shown that linear growth correlate with organ growth better than weight gain. In this study of 71 preterm infants, lung function tests were performed at 6 months corrected age, and then again a year later. Multivariate analysis showed that the increase in height velocity is the main factor associated to the improvement of lung function, but not the increase in weight. Unfortunately, with difficulties in obtaining accurate length measurement, linear growth is often overlooked in the NICU. Most attention is paid to weight gain, and we often try to provide lots of calories when weight gain is less ideal. As a result, we would see growth curves like this one, with rapid catch-up in weight gain, but not linear growth. Therefore, the weight for length curve took a turn to over 98th percentile. And we will end up with a baby with the so-called BPD stature. And this kind of BPD stature is what we described as short and chubby. I hope after this talk, if you have not done so, you will start to pay more attention to appropriate growth, what we call proportional growth, aiming at a weight to length ratio around 50th percentile. A common question people often ask is whether we should restrict fluid in order to prevent BPD. I think that comes from some retrospective observation. Here I gave one example, that the retrospective study looked at found that high fluid intake in the first 10 days of life is associated with BPD. However, we need to remember the expense of fluid restriction is that you may not be able to provide adequate nutrients for the growing preterm infants. In reality, we do not know the best fluid balance for BPD prevention. One meta-analysis found that fluid restriction may be helpful in decreasing hemodynamically significant PDA and an EC, but had no difference in the outcome of death or BPD. A 2017 Cochrane review tried to answer the question, can fluid restriction improve outcome for infants with evolving or established BPD? Unfortunately, they found no suitable studies. In the end, they only included one small RCT that compared high fluid volume with a lower fluid volume in 60 infants require oxygen at 28 days of life. This study found no difference in duration on oxygen, needs of discharge on oxygen, length of hospital stay, or weight gain. Due to the fear of an EC, many neonatologists are reluctant to feed extremely preterm infants. Our feeding practice would affect the outcome of these infants. A study published in 2018 compared the feeding practices of 5 NICUs in Guangdong province in China and 8 other NICUs overseas from US, Europe, Taiwan, Africa, and Oceania. They found that despite the babies in Guangdong were born at higher gestational age and higher birth weight, these infants were mostly fed with formula and took longer time to reach full feeds with slower growth velocity. However, there were no difference in the incidence of NEC. However, we can try to overcome our fear and improve our feeding practices through education and standardized feeding protocols. Here is an example of what we have come up with. In Guangzhou, we have set up our unit feeding protocol based on current available evidence and also our local resource. A year after the initiation of standardized feeding protocol, we found significant improvement in the time of feeding initiation and time to full feeds. We also were able to improve enteral feeding. Because of this improvement in enteral feeding, helped us to shorten the duration of TPN and also central line placement. As a result, the central line associated infection rate also decreased. We have spent a lot of time on nutritional support. However, without adequate respiratory support, it would be very difficult to achieve good growth, and inappropriate respiratory support can contribute to lung injury. Therefore, I would now like to switch my gears to discuss how we can provide appropriate respiratory support to promote growth and avoid lung injury. First, I would like to emphasize the importance of providing adequate respiratory support, which not only can help minimize energy expenditure from excessive work breathing, but also extremely important for supporting good neurodevelopment. In an early study, Demir and colleagues measured energy expenditure in infants with or without BPD. They found that daily energy expenditure is 16% higher in infant with BPD, and the energy expenditure correlated with respiratory rate and oxygen requirement. When respiratory rate is higher than 60 times per minute, an extra of 7.5 kcal per kilo per day is needed for every 10 breaths above the 60 times per minute. Next, I would like to discuss the importance of appropriate oxygen therapy to avoid both hyper or hypoxia. Unfortunately, we still don't know the best level of oxygen to use when we resuscitate extremely preterm infants in the delivery room. Some studies suggest it is reasonable to start from 30% FiO2 and titrate based on the NRP minute pulse goal. However, to do this, you will need to have the capacity of monitoring saturation and titrate oxygen in your delivery room. Here, I would like to do a quick poll regarding the availability of oxygen blender in your delivery room. Let's take a little time and see what we get from your answer. Okay.
So almost 54% has answered, and here are the results.
Okay. All right, I'm glad to see 61% says both in the delivery room and the operating room. That's great. And that's actually very similar to what we found in China. Well, I would say it's better than what we found in China when we did the survey back in 2021. But when we looked again last year, it did improve. So here is the result of our quick survey in China back in 2021. As you can see, most of the hospitals did have a pulse oximeter in the delivery room. However, close to 60% of hospitals do not have an oxygen blender either in the delivery room or in the operating room. But like I said, in the recent years, it has been improving quickly. So how about the oxygen saturation target? When the baby gets into our NICU, we need to set our alarms for the pulse ox level. So I'm kind of interested to see what your saturation targets in your unit.
%63% has responded.
Okay, nice. I see 81% said 90 to 94%. Great. So I think this level probably comes from the new prompt study, because this is, in my view, is the best study we have done in our neonatology society. And it's a multi-center international efforts. So in this new prompt study, it's basically the prospective meta-analysis of 5 RCTs looking at similar oxygen saturation targets. So they looked at the low saturation target range of 85 to 89% versus 91 to 95%. And the low SpO2 target compared to the high SpO2 target actually had no difference in their primary outcome of death or neurodevelopmental impairment at 18 to 24 months corrected age. However, the low saturation target group did have an increased incidence of risk of death, severe neck, or surgical PDA. And on the other hand, when you're having high oxygen saturation target, you may end up with more ROP needing therapy and also more BPD. So to balance this, the International Neonatology Society has come up with agreement of targeting 90 to 94% in most places. And a lot of places would suggest to set your alarm at between 88 to 95%. But this is, varies from unit to unit. However, even though we know the saturation target range, how do we do in real life? And this is a quality improvement projects that we have done back in 2021. And we presented our result at Pediatric Academic Society meeting in 2022. And what you can see from this figure is that we looked at the average time a baby would spend in that range, in the 90 to 94% range, 94% range over a 24-hour period of time. And on the left side, you can see, unfortunately, our babies only have 25.7% of time actually stay in this range. And over 60% of time, the babies actually stays in over 95%. So even though we know the target range, but in reality, to achieve that is actually quite difficult. And we did this quality improvement project to improve it. And our target is actually just go above towards 40% of time they can stay in the range. And it's actually already very hard to achieve. In addition, a lot of units I have seen in China use unblended oxygen in five years ago when I came to China. And nowadays, a lot more units actually use blended oxygen now. And in this study, they looked at 33 very low birth weight infants at postnatal age of between 14 days to 58 days. And you can see from this study, all these babies were only on nasal cannula of less than 2-liter flow, but they were given unblended oxygen, so 100% oxygen through nasal cannula with variable flow. And the researchers measured the oxygen saturation, the FiO2 content in the hypopharynx directly. And what they found is that with increasing flow, of course, the oxygen concentration increases. But there is a wide variability in individual patients. So the same flow, for example, same 2-liter flow, you may end up with 50% oxygen, but you may end up with close to 90% oxygen. And also, this is very significant in that the smaller the infant, the higher the oxygen content it will achieve. So in this figure, you can see in the babies, the less than 1 kilo, with 1-liter nasal cannula, you can get about like close to 80% oxygen. And in recent years, the non-invasive respiratory support method have kind of quickly developed. And over time, more and more babies actually do not get intubated right after birth. And this is a study looking at comparing to mechanical ventilation, different methods of non-invasive support and giving surfactant, comparing the result to mechanical ventilation in terms of whether how they affect the risk of death or BPD. And you can see from this meta-analysis, when they looked at 30 studies, they look at babies born at less than 33 weeks gestation and recruited within 24 hours of life. The LISA with CPAP group has the lowest risk of death or BPD at 36 weeks post-menstrual age. The second best is in-shore method. In another word, don't just intubate or don't intubate for long. You pull the tube and don't do mechanical ventilation if you can help it. However, with these development, a lot of people feel that I cannot intubate anybody, and I really have to extubate as soon as I can. However, when we try to avoid mechanical ventilation at all costs, you may end up with persistent severe work of breathing, recurrent bradycardia and desaturation episodes. The baby may not be able to tolerate routine care and activities. They may not grow well because their energy expenditure from breathing is extremely high. And a lot of units would give repeated course of systemic steroids to keep this baby from intubation. On this slide, you can see this baby, the CT of one of my patients from Shah. She was actually only intubated for less than a month, but stayed on non-invasive support for 5 months. And this is her chest CT after she came to Shah. And I'm sure none of you would say this lung is without injury. So when you have these happening, the baby will end up with extrauterine growth restriction, and they won't grow their lung. And also because of their activity is so restricted, they can't learn what they're supposed to learn. And that would affect their neurodevelopmental skills. So we need to ask, is it worse to avoid intubation, avoid mechanical ventilation at all costs? We need to think about the benefit of avoiding intubation, whether that benefit worth the risks. When we have to intubate a baby and leave the baby on mechanical ventilation, we need to try to do it well. And here, the key we think is to avoid over or under ventilating during the time that you're mechanically ventilating a baby. So in another word, if we see the pictures here, we want the baby's lung to expand well and don't collapse entirely during expiration to maintain a good FRC, functional residual capacity. What we don't want is overextending the lungs during inspiration or totally collapsing the lung during expiration. And what is the worst is that we cannot ventilate these lungs at all, that we cannot expand these lungs and the lung remains collapsed during extubation too. So in recent years, a lot of studies have examined the effect of volume targeted ventilation, because we now know that what we have called pressure injury, pressure related lung injury, is a lot to do with when we give high pressures, we actually expand the lungs. So the emphasis on volume targeted ventilation had brought a lot of studies. And in this meta-analysis published in 2017, you can see that when they compared volume targeted ventilation in the early postnatal days to the pressure controlled ventilation, you can see that it not only decreased the incidence of death or BPD at 36 weeks, it also decreased the risk of pneumothorax. It has less hypocarbia, means like too low CO2 level. There are less severe IVH or PBL, and also the days on mechanical ventilation also decreases. However, what is the target tidal volume we should shoot for? We often talk about 4 to 7 ml per kilo. However, in reality, we really don't know the best tidal volume target because we do not have enough data on what is the best volume. In a small sample study, a group actually looked at different tidal volume and the effect on lung inflammation mediators and markers of lung injury. And what they found is that when they compared small tidal volume, 3 ml per kilo, as compared to the common 5 ml per kilo volume, there is increased inflammatory mediators in the tracheoaspirates. And when they used less than 4 ml per kilo of tidal volume with a low PEEP of less than 3 to 4 centimeters of water, the markers of a lung injury also increased. So what I have to say here is, unfortunately, we do not know the best target. And we need to really look at the baby and change with the different disease state. But we cannot provide very low tidal volume for sure. But what is the higher amount limit? We actually don't know. And the other thing that is very important when we maintain mechanical ventilation is to maintain the end expiratory pressure. And this is not only important during intubated mechanical ventilation, but also non-invasive support. In the baby, when we resuscitate a baby in the delivery room, Even these extremely preterm infants did not have significant work of breathing. They actually, because of their physiology, they are very easy to collapse their lungs and very hard to recruit their alveoli. So it is actually important to provide adequate support through giving enough CPAP or PEEP. So even the baby has no significant work of breathing, you still need to put this baby on CPAP. And also we need to avoid bagging these babies without control. So I'll give you some example later. And when we provide mechanical ventilation, we need to provide them adequate PEEP. There are lots of people really afraid of PEEP, and we call these people PEEP phobia. And the reason for that is a miss in our understanding. People think that because of high PEEP would impede venous return, therefore PEEP should never exceed 6 to 8 centimeter water. And when we mechanically ventilate a extremely low birth weight infant less than 1,000 grams, we should give a PEEP less than 3 to 4 centimeter water. And the previous study I've showed you, when you use too low a PEEP, the lung injury marker actually increased. And when the baby is extremely small, extremely young, their elastic recoil of their chest wall is actually more than others. And it's actually more harder for these baby to maintain adequate FRC. So as a result, they really should be provided enough of a PEEP to maintain their FRC. And when you don't give enough PEEP, and this is what's going to happen. This is a CT scan of a baby ventilated for a little bit. And then you can see when you don't give enough PEEP, you would end up with very uneven ventilation, with areas of very ventilated lungs or very collapsed areas. And in between these areas are the areas that repeatedly open and close. And in these open and closed areas, that will really cause shear injury from this repeated expanding and collapsing. And I have mentioned that we need to really try to avoid uncontrolled PPV. This is a picture I downloaded from the Chinese web, and this is from many years ago. People posted a resuscitation of a newborn. And you can see they're bagging this intubated baby with self-inflation bag without a pressure gauge. And you can see from our NRP books, every of these pictures has a pressure gauge. And the chest X-ray from the bottom, it was from one of our babies in Guangzhou. The baby was had a cold event and resuscitated. And this, we happened to have a chest X-ray one day before resuscitation and one day after resuscitation. And some of the visiting docs asked me, how come just one day this baby's lung changed so much? And the second day after resuscitation, this lung becomes so much more cystic looking. And when I investigated during the resuscitation, the baby was bagged with self-inflation bag without a pressure gauge and without control. So when you're in a hurry and in an emergency, people often forget how much pressure you're applying to these babies when you're trying to bag the baby without a pressure gauge. The other thing that is very popular in recent years is permissive hypercarbia. However, where is the evidence of permissive hypercarbia actually can prevent BPD? And where is the evidence that they actually is safe? There are lots of theoretical benefit of permissive hypercarbia, including you can use lower mechanical ventilation settings and may be able to extubate babies earlier. However, here in this table, I listed several studies in recent years the most famous one is probably the Phoebe trial that was done in 2015. This trial was actually stopped earlier for no benefit and also trend towards benefiting the controls. In the bottom line is we do not know what is the safe value of permissive hypercarbia that actually would bring benefit and not cause harm. As we can see in some of the studies, it shows that higher mean CO2 and higher variability and lower pH is associated with death and severe IVH, right? So we do not know what is the level of the permissive hypercarbia that is beneficial without harm. So I would caution the liberal use of permissive hypercarbia because the current evidence failed to demonstrate the efficacy of this approach in the reduction of BPD. And it also raised more concerns for its safety. The timing and range of the PCO2 that may provide benefit without increasing adverse events, adverse outcomes, it's actually not known. Here, I show you another example. This is the CT scan I've shown you before. This baby was born at close to 27 weeks, gestation close to 800 grams at birth. She had a history of Staph aureus pneumonia, was ventilated for about a month, and then on non-invasive support for 5 months. At the time she was transferred, before she was transferred to CHOP, when they called for transfer, the gas we heard was a pH of 724, PCO2 119, and bicarb 29. And the baby was setting in the 70s with 100% oxygen, with heart rate in the 200s and breathing 80 to 100 times per minute. And this baby was on a series of medications, many medications, to help diurese the baby, to give a baby a lot of steroids, decrease pulmonary hypertension, and sedate this baby, okay? However, this unit would not intubate this baby because they think intubation is evil. And this is the growth curve of this baby. And you can see there's significant decreased weight gain, length gain, and head circumference increase. But most significantly is the length. That you can see it's decreased to so low. This baby did not survive. Despite at the time when she came to CHOP, she was on close to 150 kcal per kilo per day of feeding of calories, and she was not growing. And we could not save this baby because she had such a severe pulmonary hypertension and so much lung disease. So in summary, I would say when you mechanically ventilate a baby, you need to try to achieve an open lung. And open lung means open collapsed lung and keep it open. And you can see on the curve on the right side, you need to stay between the lower inflation point and upper inflation point. You need to stay in a good range. And when we use the open lung strategy, we can improve lung compliance and minimize lung injury. But that needs adequate PEEP and volume. But also, but if we only gave high PEEP or we achieve a high tidal volume without adequate PEEP, you can cause shear force, like I have shown you before. You can cause volume trauma or atelective trauma. But if we only give PEEP only and inadequate PIP or tidal volume, we won't recruit the lung very well. And even though we can improve FRC, but the lung compliance may be low, and you may end up with CO2 retention. So in another word, when we ventilate these kids, we really need both inadequate PIP or volume and also PEEP. All right, the last few minutes, I want to talk about other therapies in the early postnatal days. The first thing I want to mention is careful respiratory care. And this is picture provided by Dr. Heisinger from Cincinnati Children's. And this is, he is a pulmonologist, and he was so surprised after a bronch. And this is actually due to suction injury. And a month after changing the suction depths, this is much, much better. And we have found many BPD kids transferred to us have significant airway injury from inappropriate airway care. And the other question is, does the PDA needs to be closed? And there are lots of reasons to close it, but there's also a lot of concerns that are raised for closing the PDA. Now, in the recent years, there has been more development of closing the PDA with early cardiac cath, with cath closure. We just had a baby in Guangzhou that it's at a weight about 1.7 kilogram, and we just closed the ductus with the piccolo occluder successfully. But we also have another baby that came very late, already established BPD, that we could not close the ductus. As soon as we close that ductus, the baby's right side heart fails. We had to take the occluder out, and the baby got better after that. But in some of these babies, closing the duct may help, but in some other babies, closing the duct may be detrimental to these babies. So closing the ductus needs to be evaluated very carefully before you do it. And we try to use a lot of medications to prevent BPD. And this is a paper published by my colleague Barbara Schmidt back many years ago. And the data actually still remains true. And you can see here, there are 3 kinds of medications actually would help: caffeine, vitamin A, and systemic steroids. However, when you look at the data here, vitamin A seems to help. However, the confidence interval is very, very wide compared to caffeine. And we'll talk about steroids a little bit more later. Here, this is a table that I put together looking at the common medications that we use in the early postnatal days trying to prevent BPD. We already mentioned the caffeine. There are data that it's helpful. But right now, I think we need to, because of the cost and also growth effect, we need to use it still as according to AOP, apnea prematurity therapy. The data for surfactant is that it does improve compliance in RDS babies. However, the cost is high, and there's no data to support that it actually decreased BPD. So we should use surfactant as per our RDS therapy and avoid abusing this medication. I've seen people giving surfactant repeatedly over time, even in a baby that is much older, and there's no data to support that kind of practice. Systemic steroid, like we have seen in the previous slide, helps to prevent BPD. However, there's lots of price to pay here. During the first week especially, there is significant increase in NDI and also increased intestinal perforation. It also caused risk of infection and growth restriction. So right now, the consensus is that we need to avoid using systemic steroid in the first week of life. And then after that, we really need to carefully evaluate the risk and the benefit balance, and then decide whether we use systemic steroids. People have also tried to use inhaled steroids, and there are studies and a meta-analysis looking at multiple studies and show that the p-value for inhaled steroid is significant in decreasing BPD. However, when you look at the number need to treat and the 95th percentile confidence interval can be infinity, which means you may treat indefinite number of babies without achieving BPD prevention in one baby. However, at the same time, some of the studies actually show increased mortality in these babies that received prolonged inhaled steroid from early postnatal days. So right now, this is not recommended for routine use to prevent BPD. The other hot topic right now in the recent years is surfactant as a vehicle to deliver budesonide in the early postnatal days. The early data from Dr. Ye's group is very promising. However, it was a small sample study that only looked at babies with very severe RDS. Recently, we have participated in their trial of less severe RDS babies, and the trial result was positive. However, in the meantime, last December at Hot Topics, the Australian group also presented their data of their RCT, and they did not find a positive result. So right now, we're still waiting for more RCTs to really decide whether this therapy is going to be beneficial or not. Right now, the NICHD have an ongoing trial, multi-center trial, looking at the same issue. Now, for the last is bronchodilators. For BPD prevention, there's no enough data. However, when you use bronchodilator routinely in a baby that is ventilated, it may soil the flow sensor and therefore may cause ventilation disruption. Therefore, we're not recommending to use it routinely. The other type of medication I want to briefly mention here is antibiotics, because I'm seeing a lot of antibiotics abuse in China. People are afraid of babies being infected and septic, and therefore use a lot of antibiotics and prolonged antibiotics, broad spectrum antibiotics. However, there are concerns that antibiotic exposure in the early postnatal days may actually increase risk of BPD. We don't know for sure. You can see from this table, the first 3 studies all reported increased risk of BPD with extra antibiotic exposure. The last study is a multi-center retrospective study. When they adjusted for confounders, they didn't find a difference. So the jury is still out about antibiotic exposure and BPD. However, with this risk, and we know there's other risk associated with antibiotics exposure, we should try to avoid abuse antibiotics. In summary, effective BPD prevention needs our care team to have a good understanding of current evidence, to use appropriate evidence-based practice in conjunction with our unit resource and also individual patient characteristics. We also need to have detailed and systematic primary care protocols in our unit, and only overall good care can help prevent BPD in these kids. If you're interested in learning more about BPD care, you're welcome to come to Philadelphia and join us for the 10th Annual Chronic Lung Disease Conference at Children's Hospital, Philadelphia. At the same time, we're also going to have annual BPD collaborative symposium the next day of our conference. And in Guangzhou, we actually have an annual conference for BPD each year. And this year, we just had our conference in January this year. Thank you very much for listening, and I would be happy to answer your questions.
Wow, that was an amazing journey through BPD, very extensive. Thank you so much, Prof. Huayan. What a way to begin this new year. Now, may I request the moderators to begin the open house?
Thank you, Dr. Huayan. It was a very extensive talk on BPD. And so it's basically, we know that it started in 1967 and started only with radiology and clinical and pathological, subsequently now phenotypic, and a lot of oxygens, respiratory support. And more we learn, more and more actually, we don't have the answer. Even after this talk, lot of things actually still, I think, spending what to answer. So I think a very important topic here, the thing what we should take, I think, is the nutrition is very important. Early nutrition. That is, we do most of the times colostrum swabbing. That's very early nutrition, and antenatal counseling of mothers to provide milk as soon as the baby is born. That's very important. And of course, adequate judicious use of respiratory care. And I think that these are two important main goals. I think we should have in our practice. Thank you so much for your wonderful talk, Dr. Huayan. Thank you.
Thank you, Dr. Professor, for an excellent talk. And I would just take some of the questions which are there in the Q&A box. You showed the importance of linear growth. There is a question that why does improved BPD correlate better with the length of the baby?
I think I only showed one study that linear growth is correlated with lung growth, with lung function improvement. And actually in the clinical settings, we do see when we provide adequate support, the baby is growing better, their BPD gets more stable, their pulmonary hypertension gets better. And what we actually see is their lungs take off. Their lungs grow much better. And that seems correlate with each other. I think there are some more studies looking at solid organ growth and linear growth, and some evidence supporting that there are more correlation in that range.
Okay, thank you.
Yeah.
One question is about what is the role of diuretics in BPD?
Yeah, I realized when I talk about that table, I realized I did not put any diuretics there.
Yeah.
Yeah. Well, I think there's lots of controversy in that on this topic. I have colleagues that absolutely do not believe diuretics, but most of us do use it, right? So I think the bottom line is there's no data to say diuretics can prevent BPD, or even diuretics is effective in treating established BPD. There are short-term studies, small sample size studies, to look at diuretics and pulmonary mechanics, and show that in some of these babies, giving a course of diuretics improve pulmonary mechanics. However, there's no data to really support it can prevent BPD. And in the larger meta-analysis or larger sample size studies, even the diuretics effect improving lung function, it was not proven. So, but we all know they have side effects. So I would say at times I still use it, especially when I see on the chest X-ray it's extremely hazy and I think there's pulmonary edema. Then I would try diuretics, but I would caution to use it as a standard therapy with large dose and prolonged use. So I would say start a trial, set a few days, either 3 days or a week, and see if you get any benefits. And if not, stop it.
Yeah.
In an established BPD, at what gestational age you stop caffeine?
So we don't have in China, I'm seeing people stop caffeine at 34 weeks. I think that's what written in the drug kind of instruction. In the US, we don't have a set date to stop caffeine. We look at babies' apnea prematurity events. We stop it when the baby definitely do not have events. But in the BPD baby, when you're intubated, there's no role of prolonging caffeine use. You're not even extubating the baby. I don't think there is a role to use caffeine in a prolonged fashion. You really have to think about the cost too.
more questions. Any information about macrolide antibiotic azithromycin?
Yeah, that's a great question. I didn't touch on that. I think there are a lot of people using it for, in relation to BPD, there are two uses of macrolides. One is the early use in early postnatal days to treat baby with urea plasma infection. The problem here is that there's no definite data that that actually is helpful. We think urea plasma infection is definitely associated with preterm labor. And when you have a premature baby, the association with BPD is probably come from baby being born very prematurely. The other thing for urea plasma infection is that it may set up set the baby on the path of inflammation even before they're born. So a lot of these babies quickly the lung become very cystic even during the first few days of life. But we have no evidence that treating these babies actually improve their outcome. And there are side effects from macrolides, especially erythromycin, that can cause pleural stenosis in the preterm infants, right? So in the US, we tend not to check and tend not to treat. I think more studies is really needed. Large sample RCTs is needed. The other way I've been seeing that peaking, like kind of increasingly more common practice is from the pulmonology side, that they actually extrapolated data from the COPD patients that they use macrolides to as a anti-inflammatory medication. So they use low dose azithromycin to treat BPD. But there's absolutely no data to support that. And actually, this is unofficial. I have a student did some animal studies and gave azithromycin from early postnatal days. It actually decreased ovulation. So we have to confirm those studies, but I think it raises a question that it may not be effective and actually may bring some harm.
Two more questions. What about these mesenchymal stem cells in the management of bronchopulmonary dysplasia? One. The second thing is nirsevimab, monoclonal antibodies.
Yeah, I think, again, I didn't put those in my talk because these are still ongoing research. For stem cell research, I think there's promises to use it. However, we do not know what type of cells, how best to get the cells, what's the dose, and the true effects of whether they can prevent or treat BPD. So I would say they're not at the prime time yet, and I would not recommend just use it. That any kind of stem cell you can get hold of, just give it to the baby. I think none of these can substitute good delivery care and good postnatal care. So I'm seeing more severe BPDs in the between 28 to like 27 to 30 week like gestational age babies in China versus in the US. I think it comes from our problem in early postnatal care. So if we can improve our routine care, you actually get a lot less severe BPD babies already. So I'm all pro research and pro development of all those new therapies. However, I think BPD is a multifactorial disease. I don't really believe one medication can solve the problem. There's no silver bullet here. So I think that's why I focus on emphasizing the routine care more than the new development here.
One question what I'm getting is that are there any tools or any parameters or scores which can help us in predicting BPD?
Yes and no. I think the NICHT risk calculator is something you can go to use. If you go to the NICHT website, you can plug in the gestational age, sex, I think, race, and also FL2 requirement, mechanical ventilation requirement, those kind of things. And it will give you a risk of death or severe BPD there. It can be used to counsel your patient. And sometimes you can use it to consider whether you give systemic steroids. The higher the risk of severe BPD, the more beneficial that your steroid may get, right? However, I personally don't use that to decide whether I use steroid, because I think before you use steroid, you need to evaluate what's happening with your baby. If your baby is actually having kind of indolent infection, if your baby keep on refluxing, if your baby keep on having other issues that cause inflammation, or your baby has not grown, right? Just use steroid to force extubation is not going to be helpful.
One question about weaning from the non-invasive support. At your place, what are how do you stop or wean CPAP? Whether you see the FiO2, you see the level of flow, or you see the corrected gestational age, how do you take a decision to stop or wean off the baby from the CPAP?
Yeah, I don't think we have a set protocol for that. For BPD kids, we tend to wean very slowly, but for early preemies, I think what I emphasize is look at your patient. Is your patient comfortable? Right. So the PCO2 level and FL and pulse ox level is just some numbers that can give you some information, but they're not the most important. I would say look at your baby, whether the baby is breathing comfortably, whether the baby have a life, the baby actually it's calm, has a awake, alert status, whether the baby can tolerate care, whether the baby is growing. I think all those are important when you decide whether you can wean or not wean the support.
Yeah, I think there's one question asking for prophylactic vitamin A in the prevention of bronchopulmonary dysplasia. Just to elaborate on that.
Yeah, the vitamin A has been used for many, many years, and it's one medication that actually have lots of animal data to support and also human trials to support. However, all the human studies are from the very early age. So our neonatal care has changed over the years. And in the recent years, I have not seen RCT in the recent years looking at the effect of vitamin A, right? The other thing is that there was a shortage of vitamin A for about 2 years, several years ago in America. There's none available, period, for 2 years. And during that time, when people look at the incidence of BPD during that time, it actually did not increase. And when the vitamin A actually went back to market in the US, it became extremely expensive. So I remember CHOP actually had a group meeting to decide whether we restart vitamin A or not. We did decide to restart, but some of our satellite unit decided not to because of the price and because of the reports of no increased incidence of BPD when you're not giving it nationwide. Yeah, so I think your unit need to decide on your own then. The data, you can argue either way.
Getting one question about hydrocortisone versus the DART regimen. Your choice?
So the data for hydrocortisone to prevent BPD is not strong. The recent NICHD trial looking at when baby is still intubated by 10 days of life and start hydrocortisone to help extubation and look at 2-year outcomes, it actually is a negative trial. So and early hydrocortisone use, there has been some data that early hydrocortisone use within the first week of life may be helpful. However, the data it's not extremely strong, and there is an increased risk of intestinal perforation. So again, you need to weigh the risk and benefit to use it. For later, bigger kids with more lung disease, my personal feeling is hydrocortisone is not as strong as DEX, and usually not very helpful in the BPD kids.
There's one question about the role of nitric oxide or sildenafil in the management of PPHN related to bronchopulmonary dysplasia.
Nitric oxide, you mean for BPD prevention, or?
That is for the the lung pressure because of BPD.
So the data for NO to prevent BPD is supported by some animal studies, and therefore there has been a lot of clinical trials looking at the role of inhaled nitric oxide in BPD prevention. However, so far, the conclusion is it's not helpful. The meta-analysis of all those studies was negative. It did not decrease the risk of BPD. And also there have been some studies showing that in the babies less than 1,000 grams, the inhaled nitric early on may increase the risk of severe IBH. So right now, the consensus is that for the purpose of prevention of BPD, nitric oxide, routine use of nitric oxide is not recommended. However, if you have a baby with early PPHN, that pulmonary pressure is very high for whatever reason, I think there is a role of nitric. However, some of the response rate in preemies to nitric is variable, usually not as high as the term babies.
I need to apologize. Apologize to interrupt actually. The Prof. Huayan, can we take another 5 more minutes? We have already exceeded the time. Can we take another 5 minutes more?
Sure.
Yeah. We'll wind up in another 5 minutes.
Yeah. Just one question about non-invasive modes. There is a lot of evidence about CPAP. What is the current role of high flow nasal cannula and nasal HFO?
Good question. Those are the things I didn't include in my talk because there are too many things to talk about. So nasal cannula use has exceeded CPAP use in the United States. And when you look at the high flow nasal cannula trial, there are several good samples trials, but a lot of them are inferiority trials. It depends on how you defined the range of inferior to the CPAP, right? So if you define it wider range, then you may find your trial result is good. But if you define it narrow, it may not be good. So I think there are also some trials that actually it's a regular RCTs to compare CPAP and high flow nasal cannula in the small babies. And those results, I think one of the trial got stopped early because of definite no benefit of high flow. In general, what we feel is that when you look at those early data for high flow that is as good as CPAP, in those trials, the number of small babies, less than 1,000 grams, less than 28 weeks, are not that many. And clinically, when we use high flow nasal cannula in these babies, they often fail. So in the CHOP unit, we do not use high flow for babies less than 28 weeks to start. The high frequency nasal ventilation has becoming popular in China and some European countries. I think we need more studies, and whether you can deliver it well, it's very important. It's not just that you can put it on at any high frequency ventilator with any nasal prom. It really has a lot of requirements to really make a good seal and you actually deliver it well. Clinically, what we have seen is the baby's head shake and the chest does not shake. And so some studies said it's beneficial, some studies said it's no effect. So I think I would not recommend routine use of it at this time. It needs very good studies, but even you use it, the interface you use is extremely important. So if you cannot use it well, might as well don't use it.
The last question. So what is your suggestions to the pediatrician when you deliver these babies to them, what they should monitor on follow-ups, these BPD babies?
The BPD babies follow-up is quite difficult. I think the few main aspect to monitor them is one is their growth, whether they continue to grow well, and second is if their pulmonary function and their these babies are at much higher risk of readmission or ER visit due to respiratory illness, especially during the viral season. So all these babies, we emphasize they need to get RSV prophylaxis. They need to get vaccines in time. We actually did a QI study, QI project at CHOP to kind of improve vaccination rate in the babies with severe BPD because nobody dared to give them vaccines. And we show that with good monitoring and group effort, we can give them, get them caught up in their vaccination, which is very, very important. So any vaccine preventable respiratory illness is very important for these kids. And the third aspect to monitor is their pulmonary hypertension. So the baby already have pulmonary hypertension should have regular echo follow-ups and cardiology follow-ups. And then the other one is neurodevelopment. So the baby needs to get early intervention. They need to get physical therapy, occupational therapy as needed, and also periodical assessment of their neurodevelopmental status.
I think we'll end up the session now because it's been a long time. And Professor, thank you very much. It's late night in China. And thank you for a very excellent talk and for clearing the queries what everyone has in their minds about BPD. There are a lot of queries and the answers are still more in research now. But I think it is safer to practice what is there in evidence rather than just doing it and giving all the drugs which have been in trials. So thank you very much for a very excellent talk.
No problem.
Thank you, Dr.
You're welcome. Thank you.
So before we conclude, I would again like to invite you all for the next session that is going to be on 7th March. That is on placental perfusion. Again, the various methods. Now we have extra placental perfusion. Various methods are the so-called umbilical cord management is what is going to be discussed again. We have the next discussion of umbilical cord management on 7th of March. So I would invite you to continue to join us in the next session as well. Before we close, first of all, I would like to thank Prof. Huayan Zhang. It is so nice of you to spare. I mean, you are very busy. I know after organizing a massive conference in China, and now before you go back to US, now we have you are here now today with us late night. So it's so nice of you. We continue to have more associations with you in the future as well. I would also like to thank both the moderators for today. Dr. Venkatesh and Dr. Sachin for having moderated the session well. I just now saw Dr. Surinder Bisht is the secretary of NNF. He is here. Dr. Surinder, you want to say anything before we close the session? You are muted, Surinder.
Thank you, Professor Huayan Zhang. It was really nice to listen in such simple way. BPD, the slide was so good. It was so simple that all the questions were just started coming immediately. And the moderators, Dr. Sachin and Venkatesh, thanks to you. And as Secretary General of National Hematology Forum, I'm thankful to all of you, especially Dr. Manoj VC, our President-elect for next year, President-elect. And it is the new next talk started today with a big bang, and we saw a very great attendance today from all over the world. Professor Zhang and I were looking at the attendees list. They were from across the world, and I think everybody got benefited. Thanks Manoj, thanks Sachin, and thanks Dr. Venkatesh.
Thank you, Bish.
So thank you. Looking forward to meeting you again, Professor Zhang. We'll close here for the today with all, and thank you everyone for joining from all across the globe. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.